So good afternoon, dear friends and colleagues. We move now to this sponsored session by Shockwave that is basically going to update us on the field of intravascular lithotripsy. The title is Introducing the Next Era of Coronary Intravascular Lithotripsy and Aero-volution in Calcium Modification. Now, I have the privilege of being chairing this session with Giulia Nardi. I will introduce the speakers in a second, but because we are in a PCR environment, in a PCR ecosystem, I thought that it would be very nice to remind you that the first cases that were shown of IVL in 2019 were in Euro4C. And actually, we were fascinated in this live case, this actually performed from our center, of seeing these amazing images. We've been talking today about cracks a lot. In 2018, nobody was talking about cracks. We didn't know what they were. We were, for the first time, seeing this distinct mechanism of action that turned to be so effective in changing plaque compliance. Now, the important aspect is that this is not a static field. Many things have been changed since the time that this technique was introduced, and this session goes about that, goes about all the changes that are taking place on the dynamic aspect of intravascular lithotripsy. The session objectives are to understand the unique mechanisms of calcium plaque modification with intravascular lithotripsy that you just have seen in the images that I shared with you, to attend a practical example of new intravascular lithotripsy technology applied to a complex real-life scenario, and also to review recent clinical insights into intravascular lithotripsy mechanism and clinical performance. And for that, we have the pleasure of having with us three distinguished colleagues, James Spratt, Ziad Ali, Jose Montero Cabezas. We will go in a stepwise fashion to understand the dynamic, so to speak, character of the changes that are taking place in intravascular lithotripsy, understanding more in depth the mechanism of action. We will have the opportunity to see a live case with the new version of the lithotripsy catheter, and then also we will have the opportunity to revisit the available evidence that we have. So, Giulia, perhaps you want to introduce the first speaker?
Presentation with Dr. James Spratt from the St. George University Hospital in London, who does not need any kind of presentation, talking about the inside of this technology, the IVL technology, about safety, consistency, and the ultrasonic acoustic output.
Great, thanks very much. Could we just get my slides up, please? Do I have to press a button? I do. Which button? Hooray! Any button. It's obviously intellectually somewhat limited. So thank you for the introduction. I'm going to talk about the mechanisms of action. Any understanding how a device works is actually really important. That sort of seems like a slightly reductive thing to say, but if you're going to get the best out of a device, you have to understand how it works. And I'm going to introduce you to some of the physics behind IVL, and the door is locked now, so you can't actually escape, even if you want to hear about physics. First thing I want to ask myself is, listening to somebody talk about physics, why should I bother? Why is the mechanism of action important? And it's important because we're confronted by a lot of biological variability. We call that what the calcium looks like, the morphology, the phenotype. But in terms of the heterogeneity, there's not only what it looks like, it's how it behaves matters to us in the cath lab. And we describe that as compliance patterns. You can see that, for example, if there's eccentric calcium, one side of the vessel will behave differently to the other side. Then there's a depth of calcium, then there's a lumen size, and all these things are really important when they come to decision making. For example, compliance tells you how a balloon expands and where the force has been applied to the vessel and whether you're going to keep the procedure safe. If you've got deep calcium, how do you access that with therapies that are just superficial? And if you've got a very large lumen and your wire or your burr isn't in contact with it, it's not going to work. So all these factors are really important in understanding how they work. And we come across these patterns sometimes when we're publishing academic papers. We talk about concentric calcium, or we talk about eccentric calcium, or we talk about nodular calcium. But the reality of day-to-day life is that patients have all of these types. So the location varies, the morphology varies, and the depth of the calcium varies. And it isn't about lesions, it isn't about calcium, it's always about patients. So how do we contextualize that decision within all these clinical variables? Is it an acute coronary syndrome? Is the patient in shock? Is it a left main? Is LV function poor? And I think this is a very important way to focus on coronary calcium, but remember, the goal isn't to fracture coronary calcium. The goal is to disrupt the calcium and minimize the vascular injury. Anybody can destroy coronary calcium. So for example, if I took a tiny bit of coronary calcium, put it on the floor, I'm not looking at anyone in particular here, but if I did do that, probably would sting a bit, and I stepped on it, I would fracture it instantly. So it isn't about force. It isn't about applying a lot of force. That can be the answer. It's not always the answer. It's about being selective. So if I ask myself the question, if I was designing the perfect device, what would it look like? Number one is that it should be target oriented. So the force should be applied at the target and only to the target. So not to the healthy part of the vessel. I don't want that to be damaged. And I want, above anything, the device to be safe. That's really important. So the questions, if we apply those to IVL, is, can a shockwave be applied safely? If so, how do they impact coronary calcium? And if we take those first two as read, how do we optimize use? So let's start with the shockwave. Now, shockwaves are acoustic waves. So they're like a sound wave, but a modified sound wave. And a shockwave is this intense, very powerful wave that travels faster than sound, and that speed creates a very strong pressure. And I'm going to show how that has been adapted. So it's been around a long time, extracorporeal lithotripsy, the very large, what we call compression wave, and that's used to transmit force to fracture pulverized stones so they can be passed out. But inside the vascular tree, we don't need all that force because we're intravascular, and therefore we're much closer to the plaque. We don't want this extremely high pressure wave. But more importantly, the negative waveform is what's called a tensile wave, and that can cause what's called cavitation effects. And the thing about cavitation effects is they're not selective for calcium, so you do not want them in the coronary artery. And they can cause damage. So to modify that waveform, we've got to do two things. Firstly, we've got to miniaturize the device so it stays within the coronary vasculature. And secondly, we've got to reduce both the compression wave and the tensile wave. And you can see the modification. This is just millimeters as opposed to quite a long time for the extracorporeal waveform. This is the IVL intravascular waveform, much, much smaller. And you can see that the peak waveform is less. The negative waveform critically is also less. So you still have a high amplitude, short duration shock wave, but you have a very small, low amplitude tensile waveform to minimize the cavitation effects. The single most important thing, if you had to have one thing that you were to take away from this presentation, is the selectivity of shock waves. It depends on the medium. So I'm going to show you a very simple animation. It's going to show the shock wave propagating through low impedance and then to high impedance material. Now, critically, think of shockwave like a bundle of energy, and that energy is not transmitted until it comes at what's called a boundary effect. And a boundary effect is the difference between high impedance and low impedance, or vice versa. So if it just goes through fluid to normal vascular tree, no energy is imparted. In other words, nothing happens. If it confronts calcium, then you get energy imparted. So this is the balloon. I'm going to trigger the waveform. It's going to pass through soft tissue. Nothing's going to happen. It's going to encounter this big impedance change. And then almost all the energy is transmitted, about 80%, and about 20% is reflected. And that transmission of energy is what causes this disruption. You also get something which is actually called rarefaction. And rarefaction is what you see when a waveform bends when going from one material to the other. You can see it when you put a straw into water, like the straw seems to take on a funny shape. Same thing happens in calcium as the shock wave goes across, and that's why the fractures that you see aren't perpendicular, they're sort of spiky, crazy paving effect. Why does any of that matter? Well, it matters because you can deliver this high pressure waveform and be confident that it modifies calcium and it doesn't do anything to soft vascular tissue. Now, maybe you've come to the conclusion in this conversation course already that concentric calcium is not the problem. If you do have come to that conclusion, I agree with you. So the question here is not can it modify concentric calcium, but what happens in eccentric calcium? So in eccentric calcium, one half of the wave, the artery is exposed to potentially high pressure, if you use high pressure balloons, for example, and the other half doesn't get modified. But with shock wave, the waveforms just pass through the tissue that's non-calcific because there's no impedance interface. And on the calcific side, that's where you get this selective effect of energy being transmitted. Again, it all comes back to the clinical effect. And the clinical effect means higher efficacy, lower injury. And I'm going to show you some thought-provoking data from a cadaveric study which compared OPN, cutting balloons, and IVL in various types of calcium. And they looked, first of all, at efficacy. And efficacy was measured by fractures. I won't get into my hobby horse of why that's not a great way to measure efficacy, but nevertheless, it's a measure of efficacy. But more importantly, they also looked at vascular injury at the part of the artery that was exposed to non-selective force, and that was a lot higher in the other modalities. And this matters most in eccentric calcium when part of the vessel could be exposed to high pressure if you're not selective in your treatment. So here you've got, first of all, the micro-CT and then the histology. I'll show you that in some detail. This is the micro-CT. You can see fractures both with the IVL and OPN. So both worked. That's great. But remember, that's not the whole goal. The goal is to do that safely. And again, no disruption of intimal tissue, even with IVL, but pretty big dissection with the balloon-based therapy. And again, I'm sort of laboring the eccentric calcium point, but that's for a reason, because I think that's the most important challenge that we're confronted in dealing with coronary calcium. An OPN and nor cutting balloon, neither of them actually even managed a single fracture in eccentric calcium, but both of them resulted in vascular disruption. And that's, I'm afraid, just physics. That's what happens. We get most of our volume from vessel stretch. And if you don't modify plaque, you're only left with stretching the other side of the vessel. And of course, there is a clinical rationale or evidence that actually IVL is extremely safe, sort of remarkably safe at this point, almost never demonstrated a perforation from direct IVL treatment. And it's very difficult to do that at 4 atmospheric pressures, of course. Second major point is, and I think this is going to be an increasing point of note, is that the field effect is maximized by the simultaneous firing of the emitters. So here you've got the new aero device that Ziad's going to show us in a second. There's 2 emitters. They fire simultaneously. So for every pulse, you get 2 shock waves. So 120 pulses, 240 shock waves. And then you ask yourself the question, well, what happens in the middle? Is that a blank spot? Should I not position my balloon over the lesion? Well, actually, what happens here is you get a summation of effect, which is due to what we call shock-shock interactions. And that means you don't have to get into the physics, that you get this consistent longitudinal profile across the balloon. It is slightly higher, perpendicular to the emitters, but there's no blind spot in the middle. There are 2 emitters, and if we look at it circumferentially, and again, this is maybe more detail than you ever thought you needed, but you signed up for it. This is an emitter in cross-section. There are 1 set of electrodes firing. There are actually 2 sets of electrodes on each emitter, and that's important because they basically compensate for the blind spot that you'd otherwise get from the emitter. So if I show you that, doesn't want to go forward this, but finally does. There's the 2 emitters. They fire simultaneously. if they fired in isolation, you would get a blind spot, but simultaneously you get no blind spot. And what that means in terms of force transmission is that you get a circumferential force transmission. And this is the example of what happens when they fire simultaneously. And there's, of course, a field effect with IVL. So in other words, the force reduces the further you get away from the emitter. And again, that's not rocket science. So it's very high, close to the emitter. You can see greater than 60 atmospheres. You go out to 3 millimeters, you're talking about 40 atmospheric pressure. So you can still see significant effect, but of course it will drop the further away it gets from the emitter. And this is what we call a finite element analysis. So I've shown you what the shockwave is doing as it propagates out. This is the impact of what it's doing. And the purpose of this slide is to show you that it's a circumferential effect. So it's both consistent longitudinally, but also radially. So in summary, this is the end of the physics lesson. Sorry about that. That it's really important, though, of course, to understand that you have an acoustic waveform that has a lot of effort and R&D and research has gone in to modify it safely, but also to give you enough efficacy to modify big chunks of calcium. And again, I think the most important thing is this selectivity, that the energy is only deposited when you encounter calcium and doesn't do anything to soft tissue. And finally, these simultaneous emitters create this longitudinal waveform, which is pretty much in a sort of cylindrical fashion around the balloon. Thanks for your attention.
Thank you. Great presentation as always. And you provide us a lot of insight about the mechanism of action of this technology. I don't know if there are any questions for the audience or...
Simon, hi. Can you maybe make a comment? Should we always take IVL balloon in ratio 1:1, or can we go with 0.5?
Yeah,
larger and the pressure? Some people, even from Great Britain, they use now 2 atmospheres.
Yeah, great question. So the question is about sizing. How should you size the balloon? Remember, you're not using barotrauma here. The purpose of having fluid in the balloon is to have a smooth acoustic interface between the balloon and the vessel. So you really want to oppose it. Your pressures can be very low. So 2 atmospheric pressures, the balloon works just as well. You have to prep it very well. So if you have a vessel in which it's, say, 3.5 here and 3.0 down here, absolutely no problem using a 3.5 in the distal vessel, or even a 4.0 if you're going back to left main and just using low atmospheric pressure. Because you're using such low pressures, there's no risk of oversizing that you would have at nominal pressure with an NC balloon.
Any comments?
So, James, one question then. The pressure of the balloon, of course, does not influence the transmission of the wave. That's something that is very important. Can you oversize, say, with a 0.5 millimeter balloon inflating to 2 atmospheres? Because that will give you more chances of, with a single balloon, being able to treat areas where you have large changes in the diameter size of the vessel.
No, totally. Absolutely, Javier. That would be standard of practice, that you can oversize easily at 0.5, probably as much as 1 if you need to in terms of vessel length. And again, compensate by just using very low atmospheric pressures. As long as the balloon is opposed to the vessel, as you say, the pressure does not influence the transmission of the waveform.
I have a question for you, Jose. Typically, the recommendation of the company is to use a 1:1 ratio, but of course, it doesn't tell you if that is assessed visually or if it is assessed with IVUS. Do you think that in many occasions you may be perhaps undersizing and therefore failing to deliver energy if you are using just the eyeball in the size of the vessel?
That's certainly a great point, but I truly believe that the imaging should guide the decision regarding the balloon size. But I also understand from the company that even if you don't have fully a position of the balloon with the wall, you are only losing like 30% of the energy delivery, right? But still you are transmitting some energy to the lesion you're treating, right? So I think most important is if I'm treating a large segment, I try to decide my balloon size based a little bit on the whole segment I'm planning to use, being efficient with just one balloon size. In that case, I will go for kind of a larger balloon to treat the whole segment?
Yeah, I think we should always promote good practice. And I think imaging is definitely good practice. But we should also realize we live in the real world and 80% of cases don't get any imaging. I think the risks of oversizing are real, particularly in the context of semi-compliant or non-compliant balloons, but they're essentially as close to zero with IVL as you can get. So I think the company always start off a little conservative because that's the role they play. I think us as clinicians can be more demonstrative about what is safe and what is good practice, and certainly an evolution of practice is to use a balloon that's slightly oversized distally if you need to compensate for those longer lesions proximally.
What happens if the balloon breaks throughout the pulses first, and secondly, if it doesn't open well after the pulses?
Yeah, so the first question was what happens if the balloon perforates? Well, it doesn't work, essentially. That's you back to zero. And that was something we saw a few years ago with the early iterations, but something now, I think that due to changes in practice and improvement in the balloon design, we don't see very often. The second question was, well, what if it doesn't work? You know, part of this conversation is explaining what therapy we're delivering. The other half of the conversation is understanding what biology is that we're dealing with. I think that half of the equation isn't as evolved as much as the first half. So there's a lot of heterogeneity in calcium. Some of that heterogeneity is down to what it looks like. Many other aspects of it are down to how it behaves, the physiology of the calcium. The closest we're getting to that is with lesion-specific density. And I think there are some exciting signs that we may be able to say what force is required to disrupt this exact calcium. We're not there now, so we're still in this, let's try this based on what it looks like. And sometimes we don't get the right answer. Final point is there will always be very, very dense, thick calcium, which may be too dense to modify, particularly if it's nodular or eccentric.
So thank you very much, James.
We can move to the next presentation from Dr. Ziad Alid from New York, who is presenting a recorded live case of IVL in complex PCI scenarios.
So I will be moving the slides for Dr. Ziad Ali, but Ziad, very nice to see you here. We can see you in the screen.
Good afternoon, right? Or yeah, that's right, afternoon.
Thank you very much for joining. And yeah, so we are ready to start your presentation, and just let me know and I will be moving the slides for you. Thank you.
Great. So right now I can just see you. So if the AV can show us the slides as well so I can see what slide we're on, that'd be great. So I wish I could be there in Madrid with you, but that's challenging with the Concorde no longer available for me to get back in time to do the live case, which will be in about an hour. And so what I'm going to talk to you about is an unmet need. I think James did a fabulous job of explaining exactly what and how Shockwave works and what amazing progress that we've made. But there are limitations. They're unquestionable. And the major limitation that we've all dealt with is the delivery of this device. It's very challenging to push this through certain types of lesions. And really, this catheter hasn't been iterated since the very, very early beginnings of Shockwave, which now is almost a decade. But Aero is an entirely new paradigm. And so let me put this in perspective for you. I, like you as an interventional cardiologist, have been told many times by different companies when a new product comes out that it's magnitudes better, more pushable stent, more deliverable. And for the most part, whenever I've used it, I've been underwhelmed. I cannot say how much of a polar opposite experience using Shockwave C2 Aero is. It is a completely different game changer of a balloon comparatively. I would never pick a C2 Plus if I have Aero available. So what are the real changes? Number one, the first time you pick it up, hopefully by May, you'll see it's much more flexible. sort of distal 35 or 25 centimeters of the catheter now flop downwards and are not nearly as stiff. I would say that the most important change to this Aero device is the distal 25 centimeters of the catheter now have a very lubricious hydrophilic coating, and I would suggest that all of you just wipe your hands with a wet glove onto this and see how slippery this has really become. There's a tapered tip, which I'll show you on the next slide, which lets it engage severe stenosis a little bit better. But honestly, one of my favorite things about this is this remodeling for rewrap. We all know that once the shockwave went in, you could pull it back, but you pretty much weren't going to get it forward. And this was really impactful. The main reason was it determined your pulse management strategy, which started from distal to proximal. That's now changed. And finally, I think the more efficient treatment time is a nice little bonus with only 5 seconds between the cycles. Next, please. So let me show you this in a little bit more detail, what's different between the catheter. So the first 25 centimeters of this new device has a hydrophilic coating that is very lubricious. It is important to note that no shockwave device prior to this in the coronary had any coating, which is some of the reason that it got stuck in tortuosity, as well as obviously in stents, as well as in hostile anatomy. This improved tip configuration is shorter and more tapered, and you can see for itself by basically thinning this down and shortening it, you can get much closer to the vessel wall and engage it better. You'll also notice that the emitters are thinned down and the balloon profile is reduced. Next slide, please, Javier. This is the details that you want to know. The key thing to determine whether you are actually using a C2 Plus or an Aero on X-ray is you'll notice that each one of the emitters has been shifted forward 1 millimeter. In the past, the Shockwave C2 Plus device, the proximal emitter, or sorry, I should say the distal emitter, was actually 4 millimeters back from the radiopaque marker. And the reason was to try to engage the lesion a little bit better because the emitter was the thickest part of the catheter. That is no longer the case. And so as a result, all of this can be moved forward. And now there's an equal split amongst the 12 millimeters with a 3 millimeter gap from the distal radiopaque marker, 6 millimeter gap to the second emitter, and then a 3 millimeter gap. Next slide, please. So what does this mean, practically? Practically, at least in the United States, a lot of C2 Plus work was happening femorally. It was often with 7 French guiding catheters because we needed space. We needed extra support. At St. Francis, which was one of the highest volume centers, maybe the highest volume center for shockwave in the world, we were upfront using a guide extension in every case as we're an extremely busy cath lab. You have Rich Schlafmitz, the busiest operator in the world, sitting in the room with you. And we often use tricks like balloon-assisted tracking and unsheathing of the device in order to deliver this. And our pulse management strategy was really distal to proximal. We would go to the most distal eccentric lesion, deliver shocks, and pull it back slowly. And for multivessel, we were actually using multiple balloons. That is completely changed with Aero. For those of you who are radial proponents, you can see that you won't need the extra support for femoral. This will slide through very easily. It's often switched to a 6 French EBU or Amplet system. We use a workhorse wire. Guide extensions are now used only strategically. We never open it at the same time. And in fact, of our 50 or so Aero cases, we probably use a guide liner in the order of 10%. It's now our primary delivery. We don't use balloon-assisted tracking. We basically take the Aero and sort of push it through. Often we have a change in our workflow where you use a 1.5 or 2.0 small pre-dilation balloon and the Aero will deliver extremely easily. Our pulse management has now a fit more with biology rather than with the necessity, where we start with the concentric lesions, delivering 10 to 20 pulses, and then using the majority of our pulses around the lesion to modify the eccentric calcium so we can maximize the luminal gain throughout the lesion. And finally, for multivessel disease, like I recently did a live case at Scottsdale Interventional Forum, I use one balloon for multiple vessels or one balloon for an LED diag bifurcation, etc. And this balloon can easily rewrap. So the best way to show you this is to actually show you in a live case. This is one of our earlier experiences, and I think this case really speaks for itself. I look forward to hearing your feedback at the end of this.
So, can we have the sound on, please?
It might.
The 3.5? 3.5, yeah?
Oh yeah. It's not going to go through the section.
Yeah, maybe not. Let's see. Okay, guys, welcome to St. Francis. I'm here with Kieran Reddy. And what we're going to do is we've got a nice case for you for shockwave. And basically what we've got is a very tortuous right coronary artery. As you can see here, this is typically something that we would consider a little bit more on the challenging side for delivery of the shockwave. First of all, of course, you can see that there's a severe eccentric calcification, which we think might impair stent expansion. So that's why we've decided to go up front. Our strategy has turned to default to go up front with trying to directly deliver the shockwave. What Kieran did is just, so you can see how pretty bad this is. What you can see is he actually wired this, and then we took a microcatheter down just to help guide through all that tortuosity, which apparently wasn't that difficult, and now we've just got, he's trapped that out. It's not going. Okay, push that a little. Let's try that one more time. C2 plus, it's not really going across. You see the guides coming back. And it's going further, right? Yeah, so just keep some gentle forward pressure. Yeah, sure. And so you can see that the C2 plus would not cross in this situation. So we're going to come out with this, and we're going to try something unique. We're going to try the aero.
For that project.
Doesn't work like that. In the marginal, you think? You know what? Why don't you put that down there and then take another wire? Is that it? Yeah, that's it. Yeah. Okay. All right. So let's see if Aero does what it says on the box, what it's supposed to do. The new next generation of IVL catheter. So let's talk about what's difference between C2 plus. Just hold this so that it doesn't get in my face, please. Okay. So what's different about this is a few things. Number one, there's a hydrophilic coating all through the catheter. Okay. So it's much more lubricious, so it should be able to cross much more easily. Okay. Just get this soaking wet. All right. The second thing is that the emitters are now equally placed. They used to be offset. Do you remember that the first emitter was 4 millimeters back from the radiopaque marker, then there was 6 millimeters, then a 2 millimeter gap. Now it's just equally split, 3, 6, 3. So that's it. And then you'll notice something about the shockwave here. I don't know if you can see that in my hand. It's much more floppy. It's much more flexible. So you can see it can turn around, make bends, and you just can't do that with C2 plus. And so the idea is that's what takes this around Shepherd's Crook, and that's what makes it much more deliverable. All right, I'm going to try the Aero one time here. Yeah. There it goes. All right. It went. Okay, so that's a nice feature. Okay, so this is a much more deliverable device. I think it's pretty good. Should I try my luck here, a little Kieran Reddy? Okay, how about delivering that all the way through? Okay, good. So let's go back here and see. somewhere like that, right? So what we're going to do is put this on the device detection. Kieran's going to take a dry cine here. Let's look at our calcium detail. Okay, so what I'm going to do here is go up to 4 atmospheres. Okay, and try cine there for me. Okay, we're going to start pulsing. Let's see if this opens up at all. That's tight. It's pretty amazing that it went through, huh? Okay, down. Wow. We weren't expecting that, were we? It's amazing it went through. It's not yielding yet. I want to pull it back just a little bit. Yeah, you can really see the emitters. Try sitting here. There it goes, starting. Okay. There it goes. It does what it says on the box, huh? That is one tight lesion. Okay. Try sitting it there, please. There you go. Okay, shockwave at work. Don't need a randomized trial for that. Okay, so how about a couple millimeters back? Got air, so we're going to de-air this. Okay, try sitting for me, please. Okay, good. Going back up.
Back up with the shock.
It's opening. Yep, that's it. We do have left 60. Okay, let's take this back a little bit more. Push that down now. Oh. This is one of the key questions, right? It's aero, can you redeliver it? So now you can see we've dilated, we've redelivered it. Oh, look at that. There we go. Now we're talking. Try sitting for there, please, Karen. Now we're talking. Now we're talking. Okay. Okay, let's do a little shockwave faux pas, which we normally shouldn't do. So why don't you take this back a little bit? We'll take a picture and then we'll see if we can redeliver it distally. That's pretty freaking good, right? We can deliver this winged arrow all the way back. Let's do our last 10 here. That looks good. All right, good. Pretty cool, huh? I mean, like the C2 Plus wouldn't go at all. We put it through the lesion. It was super tight. And then after we winged it, we stuck it back down the whole entire lesion. There it is. Forward. Take that. Okay. And 1, 2, 3, and down. Okay, picture. Okay. Wah wah wee wah.
So that's the end of the case. I think there's several learning points from this case because you saw in real time the failure of the classic C2 plus. I can't believe we're calling it classic now. And the direct difference in vivo in the same case, in the same patient, with the only difference being the device. And what you'll notice is that it completely changed our strategy. The other thing that I think was really meaningful for this case is many people consider only atherectomy for long diffuse segments of calcium. You'll have noticed that we had serial 80 or 90% lesions, all of which broke open with the Aero. And in the end, we got an excellent result with a very good stent expansion. So this was the plan to show you in real life in a case in the box, and I'm more than happy to take any questions.
Thank you very much, Ziad. Well, seeing is believing. I mean, it's really a fantastic presentation. Julia?
There is a question.
Ziad, this is Fernando. Beautiful case. I do agree that sometimes in medicine, rare cases, but sometimes you don't need a randomized clinical trial to prove something. So good. Now my point is regarding the body wire. Any concern or any advantage of having another wire while you're doing IVL?
Generally, no. In this specific case, the only reason we put the buddy wire was because we were having trouble wiring the main vessel. And so we just used that buddy wire as an anchor. In general, the addition of the wire to your shockwave efficacy is basically zero. So if anything, it just creates another layer of impedance between the calcium. So you would use it just as you normally would, but it's not part of our workflow. We just use a regular workhorse wire with Aero.
Fantastic. So, Richard, we have Ziad, we have Richard Slotnitz here sitting in the front row. So perhaps if you could handle the microphone, Richard, as he has mentioned, you're one of the highest volume operators in the world. Can you tell us your insights about the use of the Aero?
He's definitely also the highest Aero volume user in the world.
So one thing I'd like to add, Z, could you mention about a wiggle wire? I find that these calcified lesions at the right, there's always nodules. And, you know, in the past where we had to use guide extension and had difficulty getting down, I almost always use a wiggle wire in these situations because my catheters go above or below the nodule, and it makes it so much easier. So using a wiggle, and I try not to use a guideliner with the potential risk involved with it, but with a wiggle wire in this Aero, it really is a game changer, and it's really our first go-to. Bifurcation lesions, everything. It's just really nice. And the 5 seconds is good because I can get extra cases done.
I think another important learning point is the increase of deliverability. That I don't know how many of you used to predilate with a semi-compliant balloon before advancing the IVL balloon, the IVL catheter. In that case, maybe we can use upfront the IVL balloon without the need for predilatation, thanks to the increased deliverability, the hydrophilic coating.
But this is now the question. Should we, there's the official recommendation to predilate to make a channel of 1.5 to be sure our C2 plus balloon is crossing. But nowadays, James, what would you do? Predilate or not?
Yeah, I mean, I never get that excited, to be honest, about things that are easier to deliver. I mean, maybe that's just me. I should get more excited about them, to be honest. But I think the major takeaway is that we currently shock distal to proximal. And I think the balloon definitely doesn't rewrap well at all. And that creates all sorts of inefficient loops. If you miss a point and you have to go down, then you have to get the guide extension out and redeliver it and all the rest of it. I think Aero is still not going to be a balloon uncrossable lesion. I don't think it's going to address that. The only thing that I do wonder, and it'd be good to get Ziad's perspective on it, shifting the emitter that bit closer to the lesion, has that affected your strategy in terms of shock and cross rather than cross and shock?
So that's a great question. To be honest, James, the reason we haven't tested that is because we've been fortunate enough to be using Javelin. So we enrolled 31 patients in the forward CAD study. So for really tight 90 plus considered uncrossable lesions. We've had the great fortune of being able to use Javelin to cross those. So we haven't really tried Aero in that situation. But I will say that through our learning of Aero, I think that there's so little downside to using a 1.5 or 2.0 balloon. You're not going to be damaging the medial wall. Basically, all you're doing is facilitating a channel, and that just makes the delivery really easy. So I'll give you our quick experience, and that was at the beginning of using Aero, we would try to deliver it even across 99% lesions. And then somewhere about 5 or 10 cases in where we realized you don't really need to do that. And what makes this easier, and rather than sort of jamming this very expensive device into really super tight lesions, we just use a 1.5 or 2.0. In fact, often I use a 1.5, 2.0 long balloon. And once you've pre-dilated to make it space, it makes it even easier to deliver this across the lesion.
So, Sia, thank you very much. I mean, this was a fantastic demonstration of how the technical improvements that are being introduced in IVL are facilitating our work. It was an amazing demonstration. Very rarely we have the opportunity to actually see in a live case the performance of a previous generation and a new generation of a device. Thank you very much for being with us, and with this we'll move forward.
I'll see you guys in an hour and a half.
We are going to the next presentation with Dr. Jose Montero Cabezas talking about evidence from literature about IVL.
Thank you very much for the presentation. So my name is Jose Montero. I work in the Leiden University Medical Center in the Netherlands. I will be reviewing some of the most relevant evidence that we have had in the past year. We have had a grateful year for this topic. And regarding IVL, some exciting studies have been showed up covering some of the aspects that worried us in clinical practice. We'll start with the BALI trial, has been recently published in JACC Interventions. It was a randomized trial comparing patients, 200 patients randomized to conventional lesion preparation with non-compliant balloons versus IVL plus conventional preparation. So the primary composite endpoint was a fail or no stent delivery, residual stenosis of more than 20% of target vessel failure 1 year. These are the results. Regarding the primary composite endpoint, we could see that in the lithotripsy group, a significant reduction in the occurrence of the clinical endpoint, of the composite endpoint. And when we look at the all the elements of the MACE regarding residual area or target vessel failure 1 year, so the patients treated with IVL show better results. Important information, important data to help us really understanding how well can we approach calcific lesions, all of them assessed by angiography. Another study that came out this year was a shortcut trial. Unfortunately, we don't have a paper yet, so the data that we have is very preliminary. It was presented on TCT last year. This is a clinical trial as well, designed as a non-inferiority, 413 patients randomized to planned rotational atherectomy plus IVL versus a non-planned rotational atherectomy. And the patients were treated with and a cutting balloon. So when we look at the final results in terms of post-procedural minimum stent area at the site of maximum calcification, when we look at the entire cohort, we see there were no difference between patients treated with cutting balloon or intravascular lithotripsy. But the point is, if we look a little bit deeper and we analyze the two different strategies followed, so planned atherectomy or non-planned atherectomy, in patients in which were treated with this strategy, with planned atherectomy plus IVL, there were no difference indeed. But when we look at the patients with non-atherectomy and cutting balloon, actually we see that IVL was even better in terms of the minimum stent area achieved. So we have to understand that this study is not testing one device against the other one, it's testing one strategy and against the other one. But it's still important data. We hope to see the paper soon published. Another important study that we had this year, it was a victory trial. Again, unfortunately, there is no paper yet. So this study was conducted in 3 centers with high experience on the use of OPN balloon, 400 patients randomized to OPN versus or IVL as lesion preparation strategy. Again, the primary endpoint was stent expansion assessed by OCT. And what we saw here is that OPN patients with lesion preparation with OPN were non-inferior to IVL regarding stent expansion, and importantly, similar rates of MACE at 30 days and no differences in terms of perforation. Important data as well. We hope to see more data published soon, but help us to understand what is the performance of this device against IVL, which is now being tested as a gold standard in many of these studies. Another piece of evidence that we have this year was as well the Empower trial conducted by Shockwave. This prospective multicenter single-arm study from IVL, focusing on women with calcific coronary artery disease. In total, 400 patients, almost 450 lesions, in which IVL was the first approach in 90% of the patients. We had an endpoint in terms of effectiveness, so high procedural success, stent delivery, and quite a high rate of residual stenosis, less than 30%. And again, great safety with a target vessel failure within the 30 days of 12% and almost no complications. So important data in addressing often forgotten population in clinical trials with calcific coronary artery disease. We have a sub-analysis as well of all the disrupt studies and OCT analysis focusing on the kind of the last frontier in terms of calcific coronary artery disease, which are the nodal lesions. That was a great study conducted by Ziad Ali, in which 29 patients with calcific nodules were identified and were compared with 126 patients without nodal calcification, and comparisons were made regarding minimum stent area, expansion of the stent, etc. And that's important to see that we don't see really significant differences in terms of stent expansion and luminal gain in both nodular and non-nodular lesions. Important information as well coming from very well-structured data. So lots of randomized data, but we look a little bit to real-world data. There are many registries now going on worldwide. Some of them in Europe. We have a SHOCK India as well. We have the cath-PCI data in the USA. So shedding some light on the use on clinical practice of the technology, because still we are using IVL in many patients who are not really reflected on randomized clinical data. So registry data is absolutely crucial to understand the performance of the technology in certain clinical scenarios, technicalities associated with it, some differences in terms of phenotype of the calcification that we are treating, patients' feature, outcomes, etc. Some of them were addressed already by James. But one of them, of course, is our acute coronary syndrome patients, a population that is increasingly presented with calcific coronary artery disease. We have data from the Spanish registry in which we see that up to 30% of the patients included in the registry were patients with acute coronary syndrome. Again, we see fantastic performance in terms of safety and procedural outcomes, has been already reproduced in some other registries as the Benelux IVL registry, which included as well up to 251 patients with acute coronary syndrome. And actually, there were no differences compared with patients with acute coronary syndromes in terms of procedural outcomes and MACE. So the data that we have seen in the European environment has already been tested in the cath-PCI registry from the USA, a massive data set with almost 20,000 patients who underwent PCI with a C2 IVL system. 36%, similar data to the Spanish registry, presented with acute coronary syndrome, very low risk of complications, and we see actually importantly how the different approaches that we are observing in the use of IVL, 3% of them combined with atherectomy, 9% of them IVL only, and etc. So this is important data as well to understand that this technology is being used in this environment, and the profile in terms of safety and procedural success are really high and consistently across registries. So in-stent restenosis is one of the other issues that we are encountering. Again, we have data from the cath-PCI registry up to more than 4,000 patients with IVL used for the treatment of in-stent restenosis. Rough data, we don't have any information regarding the profile of the calcification, whether it was calcific neoatherosclerosis of extra-stent atherosclerosis, calcific atherosclerosis. We have analyzed this in a European environment as well in the Benelux registry. We try to define a little bit what kind of calcification is causing the in-stent restenosis. So we have calcific in-stent neoatherosclerosis of extra-stent calcification,
And we could see that even in freshly implanted stents, the performance is quite okay. And IVL is effectively in both the scenarios and both phenotypes. Regarding anatomic issues of the phenotypes, so lots of studies have been published in this regard. Some of them focus on the left main of specific coronary bifurcation, so we can see that increasingly in challenging anatomical scenarios, the technology is being used. We have as well the recently published Rolling Stone registry. There's quite a large registry from Italian colleagues comparing patients retrospectively treated with rotational atherectomy of IVL. We could see that feasibility, high safety again, and efficacy of both approaches. But we could see a trend to similar success rate, lower than with lower MACE of 30 days for IVL, and a trend to a little bit safety outcome favoring IVL. Again, this is retrospective data comparing two techniques, but important data as well from the European environment. Technicalities, some of them are reflected here. So complications, we already knew that this is, in terms of safety, quite a reliable technology, but we could see what kind of complications do we observe, if they are IVL related, which is almost never 1% in this data from the Benelux registry. And we could see as well, despite of the high syntax score and the complexity of the coronary artery disease that we are addressing here, the use of mechanical support is really residual. Again, most of them were really a planned mechanical support, but the need of rescue mechanical support when addressing these complex patients is really anecdotal. Regarding outcomes, we have information as well published this year from the French registry, that long-term predictors of target vessel failure in 12 months follow-up. We could see as well that the overall complications really low, the 30 months and the 30 days outcomes really low. The target vessel failure in patients of 1 year, less than 10%. And importantly, that's very interesting to see that the patients who receive all the pulses available in the balloons, they show a lower incidence of target vessel failure. Whether this is something that we might use in a clinical practice is, of course, more debatable. Finally, I would like to discuss something about mechanistic insights, some information that we have learned during the past year. Some of them was already mentioned by James. So by comparing IVL, cutting balloon, and OPN in the type of lesion that we are inducing on the calcium, we could see that IVL actually is less aggressive in the way that the sections are made, so less medial injury compared to the other two technologies. Important to understand how these different modalities are modifying the plaque. We have also as well important information regarding the effect that we have when we are applying IVL in stent. There was a study performed by my friend Alfonso Jurado. So in a 3D print model, so several techniques were compared with two types of stents. We have polymer coating stents and polymer-free stents, both IVL, saline ELCA, or contrast laser, and non-compliant balloons were applied, and then the stents were analyzed with electronic microscopes. And we could see that actually IVL and saline laser cause minimal damage to the polymer coatings of drug-eluting stents compared with even non-compliant balloons. So if we have the feeling that by using a non-compliant balloon we are being less aggressive, we might damage less the stent, we are wrong regarding according to this study. So this is interesting as well and can actually explain the good results that we observe when we're using IVL even in freshly placed stents. Finally, something about vessel compliance. We are talking about vessel compliance all the time, has been mentioned several times here. It's kind of the main goal is to modify the compliance on the vessel we are treating. Actually, Shockwave is putting a lot of effort in showing us, okay, the compliance is what you have to do, but can we measure compliance? So we know that IVL alters compliance. We cannot measure this live, although compliance modification could serve as a surrogate for plaque modification. Have we done enough to modify the plaque? Are we ready to implant the stent? When is enough? So this could be a potential mechanistic endpoint in this generation, but we have no prospective validation of this. But actually, we can measure compliance with IVUS, and this is something that Professor Alfonso here can tell us. So with IVUS, we can analyze the modification, the systole-diastolic differences in terms of area of the vessel we are treating, correcting by the aortic pressure in that moment, and we can infer compliance from here. This is something that we've done with patients from the Benelux registry, so we can correlate the gain of compliance, the delta of the compliance, after IVL, we can correlate it with the stent expansion, and actually that's the case, right? So when we have the larger the delta is, the better extent expansion we can achieve, and actually more than 80% at the minimum stent area. So this works. We can do this live, and we can actually analyze the netto value of the netto effect of the IVL when we compare this. Something has been recently published a couple of weeks ago from our group as well, where we could see if we, in a given lesion, we use a non-compliant balloon, and we analyze with IVOS the compliance baseline after high pressure non-compliant balloon and afterwards. And on the same lesion we apply IVL, we could see that there is a clear delta gain of compliance modification when we apply IVL on the same lesion that we have previously prepared with non-compliant balloon. So it works. It can be measured live and can really help us identify when have we done enough plaque modification to place a stent. New insights also published here. Maybe by modifying the plaque, we are creating these cracks, and we are preparing the vessel to absorb the drug. That's something that has been preliminarily shown in this paper here as well. Food for thought, but again, this is something that is coming up quite commonly now in the past few months. So it will be important to keep an eye on it. So these are my conclusions. The Shockwave has a strong and expanding evidence base, growing competitive environment, but now IVL has become the standard everyone else wants to challenge, and that's nice to see. We have still evidence gaps that remains, and the new approaches will likely modify the way IVL is used in the future. Thank you very much.
Thank you very much.
Thank you for this accurate presentation from literature. And I think that the emerging aspect is that the safety of this device, because the rate of complication was around 0.5% even in real-world scenarios from national registry. So maybe now we can ask if we need other study, or which kind of new study we need in order to confirm this result.
I think it's up to others to confirm their safety, right? So if safety of IVL is consistent in all sorts of clinical scenarios, or all sorts of presentations, etc. So I think that discussion we are beyond that discussion of safety already. So proving safety, I think it's pretty more than clear nowadays.
So, but in a nutshell, if you have to select one study, which study do you think that is most urgently?
I think for the consistency of the results and for testing what everyone was asking for, I would say Bali at this moment is kind of setting the grounds for the question everyone was asking, right? Is it superior to conventional plaque preparation? So beyond that, of course, I mean, you might say, well, this is not the most exciting in terms of groundbreaking idea, but I think that's kind of the study that everyone was asking for, and now we have those results now showing that the superiority. So
with this, thank you very much. This I will ask our spokesperson, Julia Nardi, to conclude with the take-home messages or key learnings that we have from this very interesting session. Thank you, Julia.
So, thank you. So we had the opportunity to see the new generation of IVL catheter, but we have we have not to forget that the technology is the same and has not changed. And it's very, very important, especially for young generation, that we have to perform this properly, because it's not a simple balloon. It's a very complex technology that we had the opportunity to learn today in this session. It's very, very important, just to sum up, that the sizing is fundamental in order to achieve the best efficacy of this device. And also a very, very important is to remove bubbles, because we know that air that are generating during the inflation can interfere with the propagation of the shock waves. And we had the possibility also to appreciate during the recorded case that the use of the stent enhancement technology in order to assess the correct position of the emitters and to check their position and in order to deliver the pulses right at the level of the tightest lesion. So I think that we can conclude that is a very versatile technology, that we can use it in several scenarios, even in eccentric and concentric lesions. And we had the possibility to learn a lot from this session. Thank you.
Thank you very much. And thank you to all the speakers and to all the participants to share the evolution of the field and how we are really making lots of progress.